I am a doctor.
I am a data collector.
I'm a pharmacist.
I am a clinician.
I am a counselor.
I am a nurse.
When the AIDS pandemic hit, we had information, but with COVID-19, we were never ready for the real impact.
We are frontline workers regardless of the pandemic.
We had to become resilient. That was our biggest motivator.
We are health providers.
We are health providers.
We are health providers.
We are health providers.
Pata, 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 ipata, pata. Ah, ngithenga thalima chika hallelujah heza hay saguquka sadibeka saguquka sadibeka saguquka sadibeka saguquka sadibeka
Até eu chego já.
Pata, 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 ipata, pata. Ah, ngithenga thalima chika hallelujah heza hay saguquka sadibeka saguquka sadibeka saguquka sadibeka saguquka sadibeka
All right, welcome everyone. Good day and good afternoon to everyone. I hope you enjoyed the plenary and you had a good lunch. I'm now welcoming you to Africa Cafe number 2, and this is on day 1 of the summit. And we are very glad to have you all with us. I am Dr. Jackie Dunlop, and I am a Nova Health Institute's pediatric HIV specialist, and we work in Joburg as well as support other districts in South Africa. And I'm very excited to be your chair today, and it's an honor to have been allowed to do this. We're going to be talking about different types of transitions that our children, adolescents, and youths with HIV experience in the course of their lifespans and their treatment. We're going to learn through some interactive case studies, as well as focus on some individualized and tailored approaches, really looking at some guidelines to try and help us navigate or help our patients to navigate these tricky time periods and experiences. So we're also going to hear from some youth and young people who've navigated these transitions personally, and just hear their own unique experiences, and also how these insights that they had led to the transition toolkit being developed through EGPATH. So before we start, before I introduce the rest of the speakers, we wanted to just do a poll. And so we're going to be launching a poll, and it should come up in front of you. So the first question is, the following factors are associated with a successful clinical care transition except, so you're looking for the wrong one. And there you can see the different options. I'm not going to read through them all right now. But please choose your single option that you think is correct. And then for the second question, which you can see is also displayed, the following are a skill required when assessing client readiness for transition, except. So once again, you're looking for the wrong answer. So I think what you can see already is that there's a lot that goes on when it comes to transitioning, a lot of skills that are required, and a lot of assistance that is needed from ourselves and from the other healthcare workers. And what we need to know is how do all those skills look, and how do we support our children, adolescents, and youth best. So in the meantime, while you're voting, I'm going to just introduce our speakers. So the first speaker we have is Dr. Judith Kosei, and she's the Associate Director of Pediatric Services for Elizabeth Glacier Pediatric AIDS Foundation, EGPATH, in Kenya. And she will be presenting on the transitions ahead, building capacity and providing guidance to support successful transitions for children, adolescents, and youth living with HIV. Then after Judith has spoken, we've got Dr. Nosisa Sapambo, who is a specialist in pediatric infectious diseases at the Chris Hani Baragwanath Hospital in Soweto, South Africa. And she will be presenting on transitioning pathways from hospital to primary healthcare, so another form of transition that children and adolescents often have to experience. Then Dr. Talia Ferreira will be, who is a medical officer at Impulweni Clinic Research Unit, which is a unit at Rahima Musa Hospital, Mother and Child Hospital in Johannesburg, South Africa, will be presenting on to transition or not. Thank you so much, Judith. I stuttered a bit, because I thought you were global. So just a correction, Dr. Judith is actually, the lead of the foundation globally, not just in Kenya. So Dr. Talia Ferreira will be presenting on to transition or not, and that will be around regimen change. So that one is a good one to stay put for. And then lastly, we'll be joined by Dr. Brian Zanoni from Emory University in the US. And he will be, with him, he will have some youth with experiences in the area of transitioning. With him, he'll have Ishmael Harelamana, who's Africa Youth Advisors, EGPATH, Uganda. And then with also Tombisi Simelani, who's with Baylor, EGPATH, and Eswatini. And then lastly, but not least, Joshua Ochieng, who is Africa Youth Advisors Kenya, and they will be presenting to us transitioning pathways, youth perspectives on the transitions. And this is between schools, health facilities, and homes, and really looking at the realities on the ground and how peer-based support and other strategies can be used to make these transitions easier, as well as their input into the toolkit. So if you would like to see more about our speakers, please refer to the bios in the program for more information. In the meantime, let's have a look at the results of the poll before we start the presentations. I'm not seeing anything, but I'm sure they're going to be up soon. So when looking at the first question, what factor is not associated with successful clinical care transition? By far the most popular answer at 63% was transitioning only children, adolescents and youth who have disclosed their status. So the implication there is that there's a place for disclosure within the transitioning process. Next up is 25% early engagement with children and adolescents living with HIV. So I think I think most of us would really like to see this early engagement. I know that sometimes it might be a challenge in a practical setting to make sure it's done properly, but I think yeah, from our perspective, that would be a good one to have in place, not have in place. And then lastly, engagement with the multidisciplinary teams at adolescent and adult clinics from the planning stage. So once again, I think it's also probably an important step, but perhaps also maybe sometimes a challenge, particularly where the multidisciplinary teams are not cohesive or don't exist at the clinic level. So I think that's, but thank you so much. We only had 8 responses though, so yeah, I don't know if everyone else was battling to access the poll. But then for question 2, the following are a skill required when assessing a client readiness for transition, except, and there 75% said that they can never have had a viral load in the past. And we know that with children and adolescents, there's often periods of virological non-suppression intermixed with hopefully good virological suppression. So certainly that's not a contraindication to transitioning them. Other options that were chosen, each at 13% or one person, they must know when their last viral load was done. And I think, yes, we would really like them to know when their last viral load was done. I think that would be really important. And then also they can name and describe their medications and doses. And I think you know, when we look at releasing our children and adolescents more into youth or adult care, we really want to make sure that they are as prepared as possible. But thank you so much for those who voted. We are, without further delay, going to go on to our speakers. So first up, we have Dr. Judith. Thank you so much.
Thank you for the introduction. As has been mentioned, we are going to focus on transition that involves children, adolescents, youth living with HIV. And I will start by giving an overview of what clinical transition looks like and how this can impact care. And I will also highlight briefly some practical guidance for stakeholders supporting different types of transition. And this will be based on our EGPAF transition toolkit. And then we'll have time for discussion and question and answer at the end of the session. Childhood, adolescence, and young adulthood is characterized by change, and this change can be at personal, social, biological, and clinic level. And living with HIV adds complexity in navigating these transitions. Additionally, children, adolescents, and youth living with HIV are vulnerable in reaching and sustaining treatment success, and also in continuity of care while navigating these transitions. It is also known that children, adolescents, and youth living with HIV experience various changes in their lives that may impact the way they receive care at the same facility or even at a new facility. And some of these experiences include moving their place of residence, either to live with a biological relative, a friend, or to live alone for the adolescents and youth. It may mean moving to a new school, be it a day school, a boarding school, or even going to college and university. For the females, adolescent girls, and young women, it may mean becoming pregnant and moving care from PMTCT to general HIV care services. or moving to different HIV care service delivery models based on what their viral load suppression is. So they may have differentiated service delivery models that require different changes, and also reaching adulthood and transitioning to receive care from the adult providers or clinics. And these are transitions in care that we must consider when we are talking about transition. And so when you consider the changing responsibilities in care, from childhood, the recipient of care is the child with significant caregiver and treatment supporter leadership and guidance from the providers. As they grow older into adolescence, there's increased responsibility for the adolescent in care and increased engagement with providers with assistance from the treatment supporter. And as they grow older into youth, they take over leadership in self-management of care and treatment. And so the role of the child, adolescent, or youth as a client continuously changes as their capacity for understanding and self-management grows throughout the transition from childhood to young adulthood. At Elizabeth Glaser Pediatric AIDS Foundation, we developed an adolescent and youth transition of care toolkit, and this was developed to address a gap that is well recognized among healthcare professionals regarding practical guidance in supporting children, adolescents, and youth living with HIV and their caregivers to successfully navigate various transitions in care and in life settings. And the aim of this toolkit is to provide practical, stepwise guidance for healthcare workers on how to implement and monitor transition processes for children and adolescents, youth living with HIV and their caregivers, including their educators and partners. And just to mention that this adolescent and youth transition of care toolkit was developed in partnership with our youth. And so in this transition of care toolkit, we define transition as purposeful and planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. And in this definition, we mentioned that during transition, it's important to consider the client, the provider, and this is the healthcare provider, including the lay providers, the care models that the child or adult are being moved to, the treatment regimens, and also the caregivers. And so it looks at the various transition from family dependence to self-efficacy, looking at the growth of the child to the level where they are employed. And the goal for the transition is to have uninterrupted and quality of care for the child, adolescents, and youth living with HIV. So the components of the transition in care toolkit include, one, an introduction, and this is where we cover the description and goals of transition in care, as well as talking about the facilitators and the challenges in transition. It also has a section of mapping, and this is where we map the type of transition, and based on the diagram you see in the middle there, be it transition directly from pediatric care to adult and general care, or is it transition from pediatric care through adolescent care and then adult and general care, or is it transition from adolescent care to adult general care? And we also include transition from pregnancy, postnatal, back to general care. Among the other components is also the stakeholder roles and responsibilities and resources required for transition. We also talk about the tools and resources for the different type of transition, and these are tools and resources to support the clinical transition, the caregiver transition across schools, and as mentioned, transition across pregnancy, and how to support these transitions carefully. The toolkit also has a monitoring and evaluation component, and in this area, we include how to identify and plan the implementation of the different transition models, as well as how to monitor and evaluate these. And as mentioned there, this toolkit also has a number of references that we used. And so in the structure of this toolkit, there are different forms of transition that are discussed and outlining key considerations and action items for each of the following steps. So the toolkit has the step that includes planning and preparation. When do you start planning for transition? What do you need to prepare for transition? And this includes planning and preparation for their current clinic, as well as where they're going to be transitioning to, which is the adult and general care clinic. It also has forms and considerations to look at involving the client, case review and assessment. And this includes assessment by the client themselves, as well as their treatment supporter. It includes forms to use to outline the transition tasks and who will do what task and how this will be monitored and reported. It includes some follow-up procedures post-transition and how to monitor these, as well as a section for tracking and reporting all these elements outlined here. And in developing the transition toolkit, we also included some quotes from some of the youths that were involved in developing this. And I see down here, I want to highlight a quote from a female in West Africa, and I quote, "It was not easy, transition was not easy because I felt like my life was so broad that I couldn't handle it myself. But I came to realize that it was my life, my ARV adherence, my health, and also my future were all dependent on the decisions and the steps I take from this moment." And so this is a quote from a female in West Africa that was involved in the developing of the toolkit. So as I come to a close, I want to highlight some of the tools included in the toolkit. And these are tools specific for the type of transition that would be supported. So these include clinical transition plan and forms. It includes readiness assessment tools, and this includes tools for the client themselves to assess their self-management competencies. It includes transition checklist right from pre-disclosure to post-transition. It has some sample scripts for providers in introducing transition to their clients, as well as guidance on the type of information to include when discussing caregiver handover with the different caregivers. And this includes medication the client is on, any allergies, and any special needs. The tools also include some sample follow-up questions that can be used to assess the client as they adjust post-transition. It also includes some considerations for adolescent girls and young women living with HIV as they experience transition around and after pregnancy, as well as models of care for these adolescent girls and young women. And the models of care may be mixed or community facility, antenatal and postnatal care, as well as PMTCT services. And the tools also include steps to support HIV care for children, adolescents, and youth living with HIV in different school settings. This toolkit and the training modules to enable the use of the toolkit are referenced here and can be found using this link. And I'm sure the organizers of this conference will also post this in the summit website. Thank you very much for your attention.
Good afternoon, everyone. I would like to thank the organizers for giving me this opportunity to speak at this platform. And what I'm going to be speaking about is looking at transitioning pathways, specifically focusing on the journey from the hospital to the PHC. So let me check with the chair whether you can hear me and I can proceed.
Looking great. Thanks, Nosisa.
Okay, perfect. So I would like to create the context that I will be speaking from. And our context is the Harriet Shezi Children's Clinic, so abbreviated HSCC, that is located at Baragwanath, Chris Hani Baragwanath Academic Hospital. This clinic was established in 1999 to look after HIV-infected children and adolescents. And you have to appreciate that Chris Hani Baragwanath Academic Hospital is a tertiary level hospital. And as such, then the greatest majority of our patients that ultimately ended up at Harriet Shezi came from being admitted initially to this hospital. So this clinic was established in 1999. And we then, over the years, accumulated a cohort of 11,000 plus children and adolescents. And in 2009, we launched our transition policy. Now, in 2009, in South Africa, there was capacity at the local clinics, PHC clinics, to actually initiate and manage children who were HIV infected. So having started our transition policy in 2009, to date, Harriet Shezi only focuses on children and adolescents with advanced or complex HIV disease. Some of the examples would be children on third-line antiretroviral therapy, or children with diagnostic challenges, or even children with opportunistic infections having failed their antiretroviral therapy and experience immunological and clinical failure. So the referral pathways that Chris Hani Baragwanath Academic Hospital get involved in. So referral into the hospital can be from some of the Southern African Development Community countries, and the specific countries that have got agreements with South Africa that actually refer directly to Baragwanath Hospital is Swaziland and Lesotho. Now, given that these kids are being referred to a tertiary hospital, often these are kids with hematological malignancies. And then if they happen to be also HIV infected, then they would end up coming to a Harriet Shezi clinic down here. So the Baragwanath Hospital has got a cluster of provincial hospitals, district and regional hospitals, as well as the surrounding PHC clinics that refer to it. The provincial hospitals that refer to us are the ones in the northwest province of South Africa. So Baragwanath is in another province, Gauteng. And then the district and regional hospitals that are assigned to refer to Baragwanath Hospital, as well as the surrounding local clinics, predominantly from Soweto. Now, once patients are referred to Baragwanath Hospital for various reasons, if these patients are HIV infected, then they would then follow up with us at Harriet Shezi Clinic. And then we would then transition them based on the transition criteria that I will mention later on, back to the regional, provincial, and SADC hospitals, to adult care, if we are dealing with youth and adolescents, within Baragwanath Hospital. But the pathway that I'm going to focus on is the pathway from Harriet Shezi to the surrounding PHC clinics. And this is a bi-directional transition pathway, because these are the same clinics that when they are dealing with an advanced HIV disease patient would then refer to us. So looking at the transition journey specifically for Harriet Shezi Clinic, which started in 2009. When we started off, we researched the literature for what was available with regards to transition pathways. So certainly in South Africa, there was no existing transition guideline at the time. We then looked at international literature, and we found quite a paucity in terms of any literature with dealing with transition pathways. We broadened our search looking at children with chronic illnesses, not specifically looking at HIV-infected children. And what we found were a few publications that were really individualized transition journeys. And we soon found that these journeys, these publications were really tailor-made to that particular situation. We learned what we could, but we took away that, we have to create our own transition pathway that would fit our existing circumstances. We then embarked on consultations with the surrounding PHC clinics, and we actually established HIV clinics within the existing PHC clinics. And we have trained the nurses that were working in those clinics and the entire establishment in terms of how they would manage children who are HIV infected. Now, around that time, there were also nurses that had been trained in NIMAT, which is nurse-initiated and managed antiretroviral therapy. So those nurses had gone through the course, but in the consultations, it came up that they lacked confidence in actually managing children, especially young children. And so we then brought these nurses into Harriet Shezi for a 2-week-long mentoring period, whereby they would gain some practical experience and as well as gain some confidence with regards to managing children. Included in these partnerships, so I think I would really like to stress the fact that this was consultation and partnership. So it was not something that was top down, that it has to be this way. So we did take in some input from the local clinics in terms of how this transition should be smoothly handled. And one of the feedback that we got from the nurses was that they were quite uncomfortable with taking bloods from children that were under 5 years of age. So we then had to create some means whereby, children that were under the age of 5 would be transitioned to PHC clinics that have doctors that work in there as well. So there's different levels of these clinics within South Africa. One thing that was quite key in this, our transition journey, was creating partnerships. And these include partnerships with community-based organizations, the PHC clinics themselves, as well as the implementing partners. And along the way, we then actually initiated the establishment of what we call the Regional Pediatric Stakeholders Forum. And this forum was designed to actually look at transition pathways, look at any challenges that would come up, barriers, and really streamline that smooth transition to PHC, as well as from PHC to Harriet Shezi Children's Clinic. Now this, looking at the value of this forum, it actually currently exists to look at all transition pathways, not just for HIV infected children. We look at emergency services in terms of ambulances, transferring patients to Baragwanath Hospital, and just look across the board. And it also works at identifying training gaps that exist. I mean, specifically for us, we focus on children that are and adolescents that are HIV infected. But our role in the forum recognizes the fact that we have to strengthen health systems overall in order to benefit all children, including those that are HIV infected. Our transition criteria, so our guiding principles were looking at retention in care. And in the context whereby, retention in care cannot be seen in isolation as the fact that you have to, I think our previous speaker has really mapped this out beautifully, that, sometimes if we focus on retention in care being retention within Harriet Shezi, we may actually jeopardize retention in care, because looking at the evolution of Harriet Shezi Children's Clinic, at the time, this was one of the first HIV initiation and management sites. So patients came from all over. And if we insist on keeping them within Harriet Shezi Children's Clinic, we may actually jeopardize retention in care ultimately, when these services are now available at locations that are decentralized and much closer to the patients. So one of our guiding principles is to ensure that we prevent treatment failure. And in preparing the patient, we would need to make sure that the patient, in terms of the level of care that is required, is appropriate to be transitioned to a PHC clinic, as well as the fact that the regimen would be a suppressive regimen. I've spoken quite extensively about how the receiving site was prepared, but part of the transition pathway is actually preparing the patient. And so each of our patients is actually individually prepared together with the caregiver or the patient. In our site, being a tertiary level referring site, we've got a signpost that indicate the fact that, we engage in a transition pathway. And throughout the care of the patient, this is then, they are made aware of this. But when the patient has actually met the criteria for no longer being complicated, that patient then would undergo, together with their caregiver, individualized transition preparation. And these can take 2 to 3 visits, ultimately until both the caregiver and the patient are ready for transition. Where appropriate, this may involve completing the disclosure process in terms of the status with the patient involved. One of the key transition criteria is that the patient must be virally suppressed. So and then it says there's 6 months post-initiation. So I've outlined how patients arrive at the Heritage Chase Children's Clinic. And I think you can appreciate that most of these patients would have been complicated to begin with. So they would have had some form of advanced HIV disease. Now, often 6 months later, we've been addressing all those issues and they are no longer complicated. If the patient is virally suppressed, then they would meet the initial criteria for transition, and then the preparation of the parent and the caregiver would begin. Sometimes we do get requests from caregivers whereby perhaps they are moving to a different province, they've changed locations in terms of where they live, or one of the transitions that has been mentioned by the previous speaker, where a different caregiver is taking over the care of the child and they live elsewhere. So when the caregiver requests this transition, we would then do that preparation to make sure that the patient is on a suppressive regimen and the level of care that we are transitioning them to is appropriate for the level of care that is required. And complicated patients then are not eligible for transfer unless it's a situation where they have to move back to a different location, and we might transition them to a tertiary level of care in that situation. But in terms of the PHC clinics, we don't transition complicated patients to them. So what has been our progress in this transition? So we started off in 2009 and we ramped up the transition process around 2013. So as an example, in 2015, we actually transitioned in that year 2,200 patients. And prior to ramping up the transition process, we actually engaged in a 6-month-long preparation of all the patients. And this was predominantly the adolescents. And this was managed by a multidisciplinary team together with a psychologist. In 2013, 2014, we did a monitoring and evaluation project where we look at, in a particular month, how many patients were transitioned, and then we would track whether they arrived at their receiving site. And so just as an example, we found that in a particular month, the best percentage that would reach in that particular month was 85%. But as we progressed with this monitoring and evaluation project, we found that there was a bit of a lag, that in the subsequent 2 to 3 months, the rest of the patients would actually arrive at the receiving site. And so we adjusted our transition protocol as well to accommodate this, because we found that sometimes patients would then sort of sit back and not actually present themselves at their transitioning site in order to get the next appointment that they would need. So looking at
Dr.
current,
Simbambo,
Yebo.
we're just going a bit over time. I'm just wondering if you could just wrap up on the sort of summarizing points. Sorry to interrupt you.
Thank you, thank you. So I think this slide is self-explanatory that, you know, having come from a cumulative cohort of over 11,000, we currently sit with a total remaining on ART of just under 1,000. And the graph at the bottom really shows that, you know, we are at a point where it is actually in equilibrium, the number of patients that get transferred in and transferred out. This is my last slide. So some of the things that we learned through this process was that, you know, you have to do your own situation analysis of what will work in your setting. Identify the resources that you need, the partnerships that you need. And of key is that this partnership is actually also a partnership between the PHCs and the transitioning site, and it's an ongoing partnership. Capacity building needs to be continuous, and you have to be prepared to make a tailor-made transitioning pathway and create standardized transition letters so that when the patients arrive at the receiving site, you've both agreed on a standardized transition letter. Thank you very much.
Thank you very much, Dr. Nosisa. We're going on to the next speaker now. Thank you.
Thank you for having me today. I will be presenting a case study, and my presentation is titled "To Transition or Not? That is the question." My name is Dr. Talia Ferreira, and I am presenting on behalf of Employee Services and Research Unit. To give a bit of background on our unit, Employee Clinic is based within the Department of Pediatrics and Child Health at Rahima Musa Mother and Child Hospital in Johannesburg, South Africa. We offer routine clinical and psychosocial services, including social work services, mental health care screening and referral, and connection with peer support groups and community-based organizations to approximately 1,600 children and adolescents living with HIV. Employee also actively participates in research activities around pediatric HIV. As we continue to optimize treatment regimens among our patients, it's important to zoom in onto dolutegravir use within our clinics. Taking a look at dolutegravir within Employee Clinic, approximately 1,015 of our total 1,600 patients are currently on a dolutegravir-based regimen, which is approximately 60%. 2/3 of our patients transitioned to dolutegravir-containing regimens were first-line transitions according to current guidelines. Patients who have not yet been transitioned to dolutegravir-containing regimens do not qualify for dolutegravir because of current 50 milligram formulations that are available. That is, they weigh less than 20 kilograms. They do not qualify for a single drug switch. That is, that they have a viral load that is more than 1,000 copies per mole. Usually, they have complex treatment regimen histories, and there may be a concern about resistance to certain drugs, particularly some NRTIs. Some patients are hesitant to switch. For example, often we see adolescents on other fixed-dose combination tablets like tenofovir, emtricitabine, and efavirenz, and they're questioning why they should transition if their treatment is working. So it's a case of, if it's not broken, why fix it? And finally, some patients may be fearful of new or different side effects that come with a new medication. To transition or not to transition? Today we have a case study of a 19-year-old female who's RVD positive with perinatally acquired infection, and she was diagnosed as a child and on treatment since age 11. She was started on a standard pediatric regimen for her age and weight at the time, which was abacavir, lamivudine, and efavirenz, and she managed to suppress her viral load for 1 year. Following that, there was a history of poor adherence, likely due to psychosocial issues present, including abuse at home by an uncle, and the side effects of treatment. Specifically, she complained of efavirenz causing drowsiness. These factors resulted in virological failure. From June 2014, she was trained to second-line regimen of zidovudine, lamivudine, and lopinavir ritonavir, which is a twice-daily regimen. From the onset, there were reports of very poor adherence due to the side effects of lopinavir ritonavir. It was noted that at best, a daily dose of lopinavir ritonavir would be taken, and this would usually be followed by vomiting. During the 18-month period on this regimen, viral suppression was never achieved, and there were multiple viral loads of more than 10,000 copies, confirming poor adherence. To note, this patient was unsuppressed on a PI for a time period of less than 2 years, which is important to keep in mind when considering potential resistance. In early 2016, she was changed to zidovudine, lamivudine, and atazanavir ritonavir. And as soon as the adverse effects of lopinavir ritonavir were reduced, adherence improved, and the patient managed to suppress her viral load to less than 400 copies. At this stage, the Everest trial had shown us that even with 2 inactive NRTIs, a patient could still suppress in the presence of an active PI. And so the patient's regimen was simplified from a twice-daily regimen to a once-daily regimen of tenofovir, lamivudine, and atazanavir ritonavir. From 2016 December to April 2021, she continued on this regimen of tenofovir, lamivudine, and atazanavir ritonavir, and managed to maintain a low-grade viremia of more than 50 copies, but less than 1,000 copies in this time period. In April 2021, the question of whether we could change her to TLD or tenofovir, lamivudine, dolutegravir was approached. And in light of preliminary NADIA study results, the patient was incentivized and told that if she managed to reduce her viral load to less than 50 copies, we would consider changing her to 1 tablet daily. This did seem to motivate her to fully adhere to treatment, and her next viral load was less than 50 copies. So the patient was changed to TLD. When considering pediatric and adolescent patients who have not yet been switched to dolutegravir-containing regimens, multiple factors should be explored. Firstly, previous complex treatment regimen histories. These usually consist of multiple NRTIs, including stavudine, abacavir, lamivudine, zidovudine, tenofovir. And often patients have been on both NRTI and PI-based regimens, as was the case in this example. Secondly, they have not been switched due to potential resistance to drugs in previous regimens. When so many different drugs have been used in a patient, what actually works? This is where the duration on treatment regimens is important. For example, the amount of time on drugs with a low versus a high genetic barrier to resistance. In order to create resistance to a drug, we need low levels of antiretrovirals plus viral replication. Therefore, in children, it's important to use drugs with a high genetic barrier to resistance so that we have a window of opportunity to correct adherence issues before resistance can develop. This brings us to our third factor, which is that virological failure, usually due to poor adherence in these patients, is extremely common. It is very, very rare that we see children who have a low-grade viremia or have been virologically suppressed throughout their lives. When virological failure is noted, it is important to explore psychosocial and other issues that are affecting adherence, including side effects, as soon as possible, so that a window of opportunity is taken while patients are still sensitive to treatment. Finally, we need to consider what will motivate the patient to be adherent to their treatment. In this case, it was 1 tablet per day. So pill burden and pill regimen simplification is important in the pediatric population. So in conclusion, we are seeing that in general, children on dolutegravir-containing regimens do really well. But it's important to remember that adolescents and extensive prolonged antiretroviral exposure and experience, usually that's more than 10 years, complicate switching to dolutegravir-containing regimens. Despite this, many children have transitioned to dolutegravir. 1/3 of dolutegravir switches within our clinic have been complex regimen or second-line switches. If a dolutegravir switch is made under these complex circumstances, it's very, very important that patients are monitored closely. For example, a viral load that is done within 3 months of starting the new treatment regimen. It can be a good idea to try and incentivize patients with a simplified regimen in order to try and suppress their viral load on their current regimen prior to switching. But it is very important not to switch a patient if there is any concern about resistance on a PI-based regimen, as we need to know if there's potential for future PI use. Dolutegravir use in pediatric regimens has not yet been extensively researched as in adult regimens. So further research and case studies are definitely needed regarding unconventional switches with complex regimen histories. Thank you.
Hello, welcome everyone to our session. This session is Youth Perspectives on Transitions in Care, Realities on the Ground. My name is Brian Zanoni. I'm an assistant professor at Emory University in the US, and I have experience in transition care with adolescents living with HIV in South Africa. I'm joined today by 2 panelists, Ishmael and Joshua, and I'll let them introduce themselves. So Ishmael, would you like to introduce yourself?
Yeah, thank you so much, Brian. I'm Ismail Halilimana Shema from Uganda, a care member, YAPS Young People and Adolescent Peer Supporter, supporting the Ministry of Health in Uganda, and also a LU Ambassador supporting the Lesbian Pediatric AIDS Foundation. Thank you so much.
Thank you so much, Brian. My name is Joshua Ochieng Olio. I am a member of Committee of Health and Youth Advisors at EDPOP. I am also an Empower for Change advocate at LVC Health, and I support adolescents living with HIV in various capacities, including psychosocial support groups. I am from Kenya. Thank you, and back to you.
Great, thank you both. So I'm going to start off the questions with a question for you, Ishmael. So as a young person, what is it like moving between clinical settings from pediatric care to adult-based care?
Okay, thank you so much. One, it is very hard to adjust, feeling of betrayal and negative feelings in mixing with adults. Because, for example, like it was a bit hard for us to go to adult clinic because we were going to miss a lot of things. For example, children and adolescents are supported with the T, which we're going to miss in adult care. So you feel uncomfortable transitioning to adult care. Less family support, they think that you're old enough to take care for yourself, and then the way they've been supporting, they tend to reduce a bit. More responsibilities, you have a lot of things to look at, different settings, lose meaningful relationship with the providers, need to learn how to create a dialogue with adults, adjusting to a new schedule and new structure. We are used to different clinic days. Now to adult clinics have also clinic days. So that also becomes a bit hard to look at. Thank you so much.
Yeah, thank you, Ishmael. Those are all important and challenging issues. Now, another challenge that we often see is moving and moving homes or even switching of caregivers. So how do you think that adolescents dealing with these problems, how should they navigate their care?
Well, I think they need to first to see how they can be proud of who they are, accept things they cannot change, disclosure and self-acceptance, and also to learn how to get usage with the new environment, and to how they can continue art regardless of new changes, and avoid bad peer pressure and risky behaviors. Also realize transition is not easy, and that's okay, and make sure they can go back to those who supported them during transition.
Yeah, those are all important points. How do you think that providers can assist during this time frame? You mentioned some things about peers and even disclosure, but how do you think the providers themselves can assist during this transition?
Those who lost parents or are no longer able to live with their parents, caregivers need to make sure they follow up and know where these young people are going to and how they can support them to continue doing service. Connect them with other young people to make them more comfortable at a clinic, and have visiting days to the adult clinic before. Give them more time in the beginning to talk through and explain things and answer their questions. And also should be part of the decision making. Peer leaders and mentors moving should be involved.
So turning to Joshua, a few questions for you. What are some of the main challenges that young people face when transitioning between school settings?
Number one, they're changing into a different environment. That means adapting becomes a problem. Number two, they're changing new friends. They're changing friends, peers, new friends. That means adapting to new friends also become a problem. Number three is they're changing the time schedules of their daily routines. That means that their routines becomes different from the various levels that they were before being transited into the next level of the school. Now, and then they are also changing mentors, because initially they had a different mentor, but now they need also to look for another mentor. Then another challenge that comes as well is stigma and discrimination. They are now seeing an issue that is becoming, they now want to start looking at how will I take my medication? How do I need now put my dates of taking my meds, put my dates for getting back to the clinic? And then lastly, they now also try to tend to be on their own, meaning that they are out of the parents' support. They're out of seeing the parents, specifically for those who are in boarding schools.
What advice would you give to the adolescents themselves in navigating the school transition?
My take would be one, know yourself better than anyone else and accept yourself how you are. That is my first advice to adolescents. And the next advice I will give to them is that their health also lies within their own hands, just as their success lies also within their own hands. Supporting them to really think of how to now use their time to also manufacture themselves on studies as well as adherence. And then last advice I would give to them is that let them consult. Let them speak to teachers, consult with teachers. If there's a decision that they think they need to take, then they need to consult before doing it. They consult their fellow peers who have been into that, and then they also connect with others too from different schools who are also undergoing transition.
No, that's great advice. And what advice would you give to providers about how they should help in these situations?
So for providers, I will borrow an idea from EGPAF Red Carpet Project. That is the formulation of bidirectional referral facility inventory. So this is where the providers are attached to, they have directional information about different schools with different teachers, point teachers, that they follow each and every individual adolescent. So I would really want to see providers having that directional facility. I would really like to see providers having the MOUs with teachers to really try and know what are some of the challenges that young people face in those schools and how they can address them so that they can have that mutual understanding and collaborative in terms of providing access to health services for these adolescents who are undergoing transition. The next thing I'll also give as a provider is to, often we need to visit our adolescents in schools, learn how do they take their pills, how do they do the drug storage, how do they have, how do they commit to adherence in as much as they are now in a new environment. This will also bring them to a comfort zone to really feel that their lives are also felt by others. And this might give them a leeway to realize their actual potential in adherence as well as in focusing education.
Those are great pieces of advice. And you know, in your experience supporting teachers and learners living with HIV in schools, what's the best way to support, to offer support that can be provided, making sure that adolescent learners have all the support that they need in the classroom and in the clinic?
One other support they need is they need to be accepted in their capacities. And this is one of the most key things that we need to really advocate for. We need to come out from classifying adolescents, from saying this one is living with HIV, so he doesn't need to eat this. This one is living with any chronic diseases, so he needs to be done this. So we need to give them an equal treatment in schools. We need to ensure that they are given equal treatment at school. Number two, we really also need to know, in as much as we are giving them equal treatment, we also need to look at equity in needs, individualized needs per adolescent in school. What does this adolescent really need to be in class, and both mentally, physically, and socially?
Yeah, thanks, Joshua. Those are great insights about some of the difficulties and solutions in dealing with adolescents transitioning during this transition time period in the school setting. So those are fantastic. So we've now been joined by a third panelist, Mitebisi. I'd like you to introduce yourself.
Hi everyone, my name is Mthobisi Simelane from the Kingdom of Eswatini. I'm a Kaya volunteer with Elizabeth Glazer here in Eswatini. I also volunteer with various organizations like the Swaziland Network of Young Positive here in Swaziland, an affiliate of Y+, and also a volunteer at a youth leader at Bela, Swaziland.
Great, thank you very much, Mitebisi. So now I'd like to actually offer questions to the whole panel. And my first question is building on something that Ishmael touched on, which is sort of building in, changing into self-management and taking care of themselves. So what do you see are the major barriers for youth to achieve self-management?
I think other barriers to self-management is about lack of engagement for adolescents, because we know adolescent stage is a transitional stage. So we need to start preparing adolescents as early as possible so that they start looking towards knowing that this is my health, this is my life, this is what I want for my career, this is what I want to see in the 2 years, 3 years, 5 years. So that means goal settings. So it means we need to start actively engaging them as early as possible. If we don't do that, then the adolescent will realize that he or she had a potential that has been sat on. Thank you.
Thank you, Joshua. That brings to the next point, and you bring up an interesting thing about preparation. So what are some other, open up to the rest of the panel, what are some other ways to prepare adolescents for this sort of change in mentality and self-management?
I guess for me, we need to first advocate for a friendly or an enabling environment, especially for the providers or the healthcare workers, since when you go to access services in an adult clinic, you usually don't like to be in the health facility for a long time. So find that the process in the health facility is taking a lot of their time, while they want to stay a limited time. So we need to foster that safer space for young people to be a priority, especially in even addressing their own needs when it comes to the adult clinic or transitioning to the adulthood clinic.
Yeah, and Ishmael, any thoughts about preparation for adolescents and sort of preparing them for self-management?
Well, for me, I think it should be a process started early, engaging adolescents and preparing them that yes, time will come, you will transition to adult clinic. And of course, during that process, like in the first days, when they join adult clinic, they need to get someone to prepare them to keep giving that support, continued support to get used with adult clinic, and to always continue intensifying follow-ups on how they understand, how are they feeling, how is it that you're now in an adult clinic, to see their views, to understand the experience attending adult clinic, to keep that support over and over, attending adult clinic. And if possible, in those first days joining adult clinic, and there are some intensifying counseling to keep supporting them to understand, and the contact persons, in the case they come for their appointment, the contact person to reach so that they can support them in some of the process, not to wait for long in the clinic, because the adult clinic is congested compared to adolescent clinic. Basically, that. Thank you so much.
Great. So now I'd love to get your opinions on advice to give first to adolescents and youth during the transition to adult care. So what advice would you give young people during this transition process?
So my advice would be to the young people during transition: don't lose track, connect with other young people who have undergone transition. Number two is accept yourself the way you are. You must be ready to learn yourself. Learn yourself to know who are you, what are your strengths, what are your weaknesses. And when you have problems and issues, then you need to also allocate yourself, somebody whom you can go to, whom you can add to and talk to about certain issues that you are really undergoing through, so that he or she can give you advice. It might be an healthcare worker or a relative, but as long as you have somebody whom you can talk to, this will help you in terms of addressing your mental health issues. Thank you and over.
That's fantastic advice. Thank you very much, Joshua. Ishmael or Mitubisi, any thoughts about advice for young people during transition?
What I can say to young people is that you need to first accept yourself and connect with the other young people who are living with HIV, who are also in the transition phase. And I will encourage young people to disclose, because if you have disclosed your status and also accepted yourself that you are living positive with HIV, you are able to transition smoothly to the other clinics.
Yes, that the disclosure is a very important issue prior to transition, and often a major barrier to transition. So thank you all for all this insightful comments today. And I think a few important themes came out, obviously disclosure being a very important one, assistance with navigation through the system, and involvement of caregivers. I think those are some three major themes that came out from the session today that can assist adolescents through the transition process.
Well, for me, it's to say that we need peer support at all levels, like from pediatric to adolescent to adult. Like there should be that continued support, and the process should start right away. It shouldn't be an event that, yes, you have now reached this certain age, you should transition to this type of clinic. There should be a process right away to guide and a checklist available to support and help those supporting transition at all levels do the work smoothly, so that if a person is ready at every stage to transition to another stage and is very happy at every stage of transition. And of course, mine is to emphasize peer support, basically. Thank you so much.
Yeah, I think that's a great way to wrap up the session in emphasizing one of the major solutions that we found, which is peer support. So thank you for highlighting that, Ismail, and thank you all for participating and for your insightful comments in this really important discussion on transition care. So thank you all very much.
Thank you. I don't seem to be visible, but I am here, or maybe I'm not on the right screen myself. Thank you so much to all the speakers. And just a note, the discussion with Prof. Brian Zanoni and Ishmael and Joshua and Tombisi was a lot longer than what we saw. However, it had to be shortened for the purposes of this presentation. So thank you all the speakers. It was a really great session. We are running a little bit over time. So what we've asked is that for any questions that can be typed into the Q&A, and our panelists will answer them in the Q&A. So if you look at the Q&A, there's open questions, answered questions, and dismissed. So questions that have been removed. But anyway, go under the answered and you'll see the answers. So I just wanted to summarize that was a really wonderful sort of whirlwind view of all kinds of transition. And I think we know that childhood up until children growing into adolescence, into youth, and into adults, we know that it's a complete whirlwind experience, and if you throw in a chronic disease such as HIV, then we really do see some more complexities and other things that need to happen. But really what we're just doing is that we're trying to care for for these children and adolescents and youth as best as we can. And I think that's what's come through at a system level, all the way through to health facility, where we see trying to choose the correct level of facility, as well as the correct regimen. And then from an individual and community perspective of how does that person, that young person, exist with and their role as it changes exist within the community and household. So I think that was really wonderful. I'm going to call on Dr. Nosisa to answer a question. So the question that was asked is, if nurses are worried about transitioning because of a lack of skills, is there any training that can be done to improve their confidence? Nosisa, you can go for it.
Thanks, Jackie. There actually isn't any formal training that I am aware of. But I think, looking at this toolkit, and I think South Africa is in the process of looking at transition guidelines. I think once you've got those guiding principles, you can actually navigate the process. There may be patients and even caregivers that have got complex psychosocial issues. Now, those patients or caregivers would need to be referred regardless. Whether you were dealing with transition or not, you would then need to sort of seek assistance of the appropriate healthcare worker, whether it be a social worker or a psychologist, to assist you with those patients regardless. So I think the confidence comes in knowing the guiding principles and just launching into it and being prepared to listen and doing it, and then the confidence comes from there. And within the PHC, I mean, in our system, nurses would be transitioning patients from within the same clinic. So yes, they would be predominantly within the same clinic, where they would be moving them from a pediatric setting to a youth facility or an adult clinic. And of course, you can easily actually monitor within the same clinic what actually happens. And I think seeing the success of their transition would also give you increased confidence. I hope I have answered the question. Thank you.
Thank you so much, Nosisa. Yes, I think you've got a wealth of experience in doing this, and I think it is not something that's unique to a South African setting, where a lot of care started off centrally and now needs to move peripherally. And how do we ensure that our PHC healthcare workers are well capacitated? Yeah, I've just got one question for Dr. Judith. We don't have time to sort of cover everyone, but I just wanted to ask, Dr. Judith, often there's a reluctance from clinicians to transition their adolescents out of care. So even if there's great guidelines in place, and we know that there's a need to sort of, that adolescents need to grow up and need to become part of adult care at some point, there's a clinician reluctance. So what could we do to really address that? I mean, even if we've got this great guideline, what would you suggest?
Yeah, thanks, Jackie. You know, you and I, being pediatricians, we know we like to keep to our patients. They're our babies, even if they're 18. But I think one of the things that we can consider is that while they get quality care in the pediatric clinic, they also need to get set to grow up to self-care. So I think one of the encouraging things about encouraging healthcare workers to transition is that when they transition, they learn more about their disease, they're able to go into self-care, they're able to access other services that adults are able to, to access and mix with other adults. So I think that growth is important, and that should be an encouraging factor for those who may be hesitating, not to transition. We always say that we need to throw the children out there so that they can, learn to swim. So maybe that's something that pediatricians and people in pediatric clinics need to embrace, so that these young people are able to get the additional support they can get in the adult clinic. Thank you, Jackie.
Thank you so much, Judith. I think we do have a tendency, it's like our own children, to hold on to them maybe a bit longer than we're ready to release them. One quick question to Brian and to the team of youth. I just wanted to find out, in light of the stigma and discrimination that you have experienced or that you've seen when disclosing your status to others, when looking at the transition through school and college and university and having to move between institutions, who do you think is a safe person to disclose to in that setting? Maybe Brian, you can answer, and then we can give if there's any other inputs from the other panel, the other team members.
Yeah, well, I think the main thing is it's really a personal decision, and it's not a standard answer for one person. But we certainly know that those that disclose and it goes well, that they receive additional support through peers. So finding the right peer to disclose to, again, that's on a personal level, but then also caregivers, the parents and even extended caregivers can offer support if disclosure is done well. And then, obviously the healthcare providers. Those are really the three main groups that offer support through this transition period. And so finding the right combination there to disclose to, and obviously the right peers, and adding on teachers to that if possible, if there's a particular teacher that may seem helpful to help along the way.
Okay, thank you. So really important to sort of make sure that you're identifying the right person, and I think it's quite a challenging one, and I wish we could hear from all our youth representatives, but we are running short of time. Lastly, Dr. Talia, sorry, Ntobisi, go for it.
Yeah, in terms of discrimination, when it comes to disclosure, the best person to disclose, especially for us as young people, for me it was easy to disclose to my girlfriend, because she was able to understand, although she didn't know much about HIV, so I was in the phase of telling him the truth.
Okay.
Eliminate all the myths that she always heard about people living with HIV.
I think that's wonderful. Thank you so much, Ntobisi. So not beyond the school and beyond the sort of institutional setting, those really key people in our actual lives that we can talk to and trust. Thank you. I'm just going to move to Dr. Talia and just quickly say, a lot of our children and adolescents have got complex treatment histories, not because they've really failed or because there's anything that they've necessarily done wrong, but just because of the changing landscape of ARVs. And it just feels like quite a tricky area. Is your advice to sort of try and assess and then to sort of do a careful transition, or a really, is that what we should do? Because it's quite a tricky area.
Yeah, thank you so much for the question. That's exactly it. Pretty much all of our children who've been on ART for more than 10 years have been on a very complex regimen before and have been on multiple drugs. So what we often do is we try to assess how they did on the different regimens, and we try to assess their viral loads at different stages to almost determine whether or not there could potentially be resistance to previous regimens or previous drugs that they were on. But it's often very, very difficult, because often non-adherence is actually the reason for their high viral loads rather than outright drug resistance. So if you're unable to do a drug resistance test, then essentially it is, at the moment, it is a bit of a gray area, and we do need to be able to just monitor very, very, very closely. So we wouldn't suggest changing anybody who can't be monitored closely or who's unable to come for follow-up, because you need to be able to switch them back if they are failing a new regimen.
Okay, thanks, Talia. So, well, that was great. Thank you. We had an excellent session. So thank you so much to all of our speakers for all the preparation work that went into providing. And of course, thanks to our organizers and everyone who contributed, and to all of you for listening. It was a wonderful session, and enjoy the rest of the summit. Goodbye, everyone.
Thank you.
Thanks, Jackie. Bye-bye, everyone.
Thank you. Bye.
Thanks, everyone. Bye.